Hi, my name is Grace Reese. I am an 8th semester nursing student at Lincoln, and today I will be demonstrating different types of suctioning and tracheostomy care. First I want to knock. Hello, my name is Grace. I will be your nurse today. I'm going to do some suctioning, and I'm also going to clean and replace the bandage on your tracheostomy. Perform hand hygiene. I want to provide client privacy and ensure the bed is in a semi-Fowler or Fowler's position. Next, I will ensure that there is a towel on my patient's chest and that they are getting hyperoxygenated before we begin. I also want to establish a non-verbal form of communication. In this case, we'll say this is Mrs. Smith. I want to verify her name and date of birth and ask her to raise her right hand if she's experiencing any distress during the procedure so that I know to stop. Next, I want to turn my suctioning on. I will turn it on to somewhere in the range between about 80 to 100 and have that ready to go and assess my patient for why they are needing suctioning. They may be gurgling, they might have secretions, they may have a decreased oxygen saturation, adventitious breath sounds, cyanosis, a rapid rate of breathing, shallow breathing, or an increased pulse rate. So once I have established my reasoning for suctioning, I will proceed. I want to test my suctioning to make sure that it works and have my supplies ready. I have my suction catheter. I have an 8 French. In there is a container for my lubricant. I also have some sterile gloves here. So once I have my patient all ready to go, I will again perform hand hygiene, and I will open my suction catheter kit, and I will very carefully remove the container for my lubricant and pour saline in, and I can lift this over the trash can first. Hand hygiene, and I will don my sterile gloves. I can get rid of my wrapper for them. Next thing that I will do is take my catheter, and first I will demonstrate nasopharyngeal suctioning. And so I will measure from the nose to the ear to the tip of the xiphoid process to know how far down I should be going. Ensuring that my patient has been hyperoxygenated, I will now break sterility on my non-dominant hand and connect the catheter to suctioning and ensure that it's working okay. Looking at my patient, I will go in, I'm choosing the right nair. I would choose this for how patent the nair is and how much room I feel like I have. I will insert until I have gone the distance that I measured, and I will withdraw slowly, providing intermittent suction for about 10 to 15 seconds. I'll give my patient about a 30-second rest in between suctioning attempts, and I will rinse the secretions out. And I will go probably about 3 times or until I feel like I've removed all the secretions, and but I won't do it for more than about 5 minutes. Typically here, I would wrap the catheter in my glove. I would toss it, and I want to document how my patient tolerated the procedure, the total amount of passes that I made with my suction catheter, and the amount, color, and consistency of any secretions. I will ensure that my patient's oxygen saturations are good before I turn the oxygen back down to the pre-hyperoxygenation level and turn my suctioning off and ensure that there's equipment for the next person that suctions at the bedside. for the sake of this video, I'm going to go into tracheal sectioning. Normally I would have a new catheter and I would be reestablishing my sterile field and re-donning gloves, but for the sake of this video, I'm going to just demonstrate here. My patient is hyperoxygenated, and so with my non-dominant hand, I can remove the oxygen, and I'm looking at the tracheostomy. I'm looking at why I'm sectioning. Are there secretions there? Are they gurgling? Do they have adventitious breath sounds or decreased oxygen saturation? Any of those reasons. I have verified my patient, introduced myself, performed hand hygiene, and have my oxygen at 80 to 120. I will once again lubricate my suction catheter in my saline and insert. Before this, I have also established a nonverbal form of communication if my patient is experiencing distress. I will insert until I meet resistance, and then applying pressure intermittently. I will suction for about 10 seconds. If possible, I will let my patient rest for about 2 to 3 minutes in between suction passes, and I suction until I have removed all the secretions, suctioning some saline to clear in between, and checking on my patient and then watching their oxygen saturation and watching them for any signs of distress. Now that I have suctioned their tracheostomy secretions, I will wrap the catheter and dispose and perform hand hygiene and make sure my patient's oxygen level is back up to normal, and we want that above 92%. I've checked on my patient. Are they having distress? And I also documenting how they responded to the treatment, the amount, color, and consistency of the secretions I suctioned, and the number of passes that it took. I will turn my suctioning off, and I will return the oxygen to the pre-hyperoxygenation level, whatever the provider had ordered for long-term care. Now that my patient has had their secretions suctioned and we've established who the patient is and a sign of distress if needed, I will provide trach care. I would like to clean around the incision and also clean the actual obturator itself. What I want to have at the bedside is my tracheostomy care kit. It's going to have sponges and scrub brushes, and it used to have 3 compartments for my saline or hydrogen peroxide to go into as well. And I want to have an obturator and a trach that is one size smaller than the one I currently have in case my patient coughs and ejects the trach from their site. I will also want to have a bag on hand so that I can bag my patient if they are in distress or eject the tracheostomy from the site. So I have knocked and performed hand hygiene. Client privacy is established. They are in the Stanley Fowler's position. I have established who my patient is, and I have explained to them what I will be doing today, which is cleaning the area of their tracheostomy, and establish a nonverbal distress sign for them. My patient has been hyperoxygenated, and I will now open my tracheostomy care kit away from me. And I've performed hand hygiene. I have my normal saline, and I will now don sterile gloves. And my thumb did touch my glove there a little bit, and that does break sterility. For the sake of this video, I'm just going to keep going. So I would have broken sterility there, but for the sake of this video, we're just going to keep going. I should also not have let my hand drop below my waist as I threw that away. Next, I'm establishing my sterile field. I have my new tracheostomy tie. I have my supplies for cleaning around the tracheostomy itself and my scrub brushes. I have a new trach sponge. I have gauze. I would normally have a sterile packet of saline in this container, and so for the sake of this video, I'm going to pretend that this is a sterile saline container that came from this kit and is sterile, so I would not be breaking sterility touching it. And I'll pour saline in 3 containers. Next, I will break sterility on my non-dominant hand, remove the oxygen, and remove the center of the trach, pulling it out. And I will drop it in compartment 1 of the normal saline, fully submerging it, taking out with my non-dominant hand. With my dominant hand, which is still sterile, I scrub the trach thoroughly and then place it in the second container of saline, which I then take it out of the second container of saline with my dominant hand and being careful to preserve my sterility, reinsert it. Next, I remove the old dressing from around the trach, and I'm observing the tracheostomy site for redness, irritation, secretions. Hopefully I have sectioned all those adequately. With my dominant hand, I'm taking swabs in normal saline. And I am cleaning thoroughly around the trach site before discarding. And I want to use quite a few of these to really get that area super clean. If there's some crusty secretions, I may want to use hydrogen peroxide to really get those off. And then I could also use gauze dipped in normal saline to clean around the site as well. I want to make sure that the area is very dry, so I'm going to take a gauze square, and at this point I am and I'm drying around the site. Next, I'm taking, with my sterile hand, I'm taking my new trach square, and at this point, this is my last step, so I do break sterility here, but I'm inserting that up around the trach, making sure it's in between the trach and the skin. And then my last step is that I typically would have a partner here to help me hold one side. For the sake of this video, I'll be doing it by myself. I will remove the trach collar and place a new trach collar on. I'll go ahead and put this around back so I have minimal time with it not being connected. I'll detach one side at a time. Removing the old one. And I want to make sure this is snug, but it's not too tight. I should be able to fit about 2 fingers in between. And there you have it. And I want to ensure that how my patient is doing okay, putting oxygen back on, but turning it down to the pre-oxygenation level. Want to check on my patient, how are they doing, how they tolerate the procedure, and then I want to document how the tracheostomy site looked, whether there was any redness, breakdown, secretions when I cleaned, what did the bandage look like was there bleeding, and I want to ensure that I document all of that, how my patient oxygenated and at rest, and that is it.